Is Dr. Poulami Datta there? She'll be presenting a case when not to operate, a lesson with traumatic cyclodialysis cleft.
Is Dr. Ananya there? No, so we just have one more presentation left, Dr. Anshika, right? Ananya is not there? Okay. So we will be yes.
Good morning, everyone. I am presenting a case when not to operate, a lesson learned with traumatic cyclodialysis cleft. In this case, a 7-year-old boy referred from outside presented with the chief complaint of gradually progressive visible swelling over the white of his left eye for the last 6 months with mild redness in the left leg. On further history, he has a history of trauma with stone 3 years back, for which he has suffered limbal rupture from 3 to 5 o'clock, and which was repaired under general anesthesia, and previous documentation revealed a best corrected vision of HMCF in his left eye and 6/6 in the right eye. Sorry. On further examination, the right eye appears to be normal, but the left eye showing sluggishly reacting pupil and a large transluminant vascularized leg measuring 10 into 5 millimeter in size, extending circumferentially from 12 to 5 o'clock, encroaching into the temporal cornea, but the nasal cornea was clear, and anterior chamber was shallow, and lens was cataractous. And further examination, IOP was low, and central corneal thickness was high, and we could not do gonioscopy because of the encroachment of the swelling over the cornea, and dilated fundoscopy was also not done. So we have done ultrasonic biomicroscopy, which has shown a gap, visible gap between the ciliary body and the scleral spar, and which was communicating with the suprachoroidal space, causing a traumatic cyclodialysis cleft. So we have planned conservative management with topical cycloplegic with atropine, 1% BD in the left eye, and UBM guided cryotherapy, and if no response, then surgical repair of the cleft along with lens extraction and IOL placement. But after 3 months of that, the size of the bleb started reducing, and by 6 months the bleb has completely resolved, and IOP being normal to 11 millimeter of mercury. And we have done the repeat ultrasonic biomicroscopy, and which has shown the spontaneous closure of the gap between the ciliary body and the scleral spar. The vision remained poor. So cyclodialysis cleft is a traumatic or iatrogenically induced pathway between the anterior chamber and the suprachoroidal space, which increases the uveoscleral outflow. There is no relationship between the cleft size and the degree of hypotony. So the first clue is the low IOP, and which was confirmed by gonioscopy, UBM or ASOCT, and managed by medical, laser or surgical technique. For small cleft, typically less than 4 o'clock, mainly the intervention is medical treatment with topical cycloplegics, often without steroid to promote scarring. And if no response, then treatment is transscleral diathermy or transconjunctival cryotherapy. And lastly, cycloplexy through the partial thickness limbal scleral flap. So as per published literature, these are some published literature regarding the minimally invasive technique in cyclodialysis cleft. So in conclusion, this is a rare case of which it has shown the dramatic resolution with a conservative treatment alone. Thank you.
Okay. So here we learnt about when not to operate. So can you tell me some indications where you can operate on such clefts?
If conservative treatment, after conservative treatment, it has not resolved, we have planned for the transcranial diathermy or surgical excision of the cyst along with cataracted lens extraction.
And some patch graft has to be done because that area is thinned out already.
Yes.
Any questions from the audience? So post-operative hypotony, if the globe is intact, then one should think of cyclodialysis cleft. Post-trauma or post-surgical.
So I'm completely, out of my depth here. I had no idea at all. So I'm asking as a novice, how do you diagnose a cyclodialysis cleft? And
at first, the child has presented with a swelling and with a history of trauma. So we have tried to do gonioscopy, and it was associated with the ocular hypotony. So we have tried to do gonioscopy, but the gonioscopy could not be done, and dilated fundoscopy also could not be done. We have thought of traumatic retinal detachment can also be done, can also be there. So we have tried to do USG B scan and UVM scan. So in USG there are no specific findings, but USG B scan we have seen there is a visible gap between the anterior chamber
Can you
and the
please show it
supracoronal
again?
space.
Yeah, just slides again. Please. Yeah. Can you please point it?
Uh,
You have a pointer?
pointer.
No. You have a pointer there?
The image quality is very poor. So
But it's still okay.
Pointer
there is
working?
Yeah, yeah, it's very fine.
this one.
Come here and show it with your finger maybe here, on the lower one. Okay. Gap between the CT and scrotum. Okay.
And after conservative treatment,
So this is presented to you after how many days of trauma?
no, it may be iatrogenically induced also after
No, this patient presented
this
to you
patient with the trauma with the stone
how
3
many,
3
days?
years back.
3 years back.
3 years back.
Fine.
Okay. So UBM is important, is it?
Yes.
Okay, great.